be a tough act to follow. A great talk by David there. Luckily, I have two helpers from the lab who are here with me today. And I just wanted to thank the organizers of Kimberly and others for the opportunity to come here. This is a real pleasure to meet you and interact with you, and for us especially, spending most of our days and nights in the lab. I think the ability to meet with you and understand the challenges that you face is really empowering and brings meaning to the research that we do. So we'll go ahead and get started. So yeah, as you recognize, there's a real urgent need for targeted chordoma therapies. One really stark statistics is that, over the last 10 years or so, there have been 26 drugs approved for breast cancer, but 0 new drugs FDA approved for chordomas. The current standard treatments of radiation and surgical excision are really insufficient, particularly when there is a relapse that occurs. And obviously with programs like Amico, there's opportunities to go beyond the diagnosis of chordoma and understand the molecular mutations that occur within the tumor. At the same time, we know that the molecular mutations themselves don't always predict response. In some cases, the same mutation that occurs in one tumor and works beautifully does not then translate to other tumors. An example of that is the BRAF mutation, which predicts beautifully the response to a drug called vemurafenib. That same mutation in a colon cancer, however, does not do so. So it's very important to then have models and abilities to test therapies directly in chordoma samples. And that's what we'll be telling you about today. The other, I think, challenge that we face with chordoma research is really a challenge that is faced by other rare cancers. And I showed a few of the challenges that we have here. Really the big one is funding, of course. So to do research, to undertake these programs, whether it's our own research or Amico, requires high level of funding. And you can see here in this bar plot, we're looking at the percent of research that's allocated to these different cancer types as a fraction of the total cancer burden and also the deaths. And you can see, while we're doing a great job, this is actually Australian data, by the way, we're doing a great job for cancers like leukemia, breast cancer, prostate cancer, some of the other big ones. As a whole, you can see that rare cancers are really significantly underfunded, and that's really not justified when we're considering the overall mortality that the patients face. The other issues with rare cancers like chordoma, of course, is resources, and that there are different flavors of that. One is the fact that the cancers are so rare that it's difficult to get hold of tissue samples to generate disease models. The biobanks can be fragmented in the sense that there might be one sample that is in Sydney and another sample might be in Los Angeles. And how do we really centralize our ability to work on chordomas? The other one, of course, is fewer disease-specific therapies and less engagement by industry. So industry as a whole, pharmaceutical companies, they are commercial entities, and they will want to put a new drug for a big cancer like breast cancer or colon, lung cancer, even if that drug might only move the dial by 5%. So there's very little to no attention to these rare cancers, and that's where there's a challenge, but also an opportunity for us as academic researchers to work in this space. So we've developed a program over the last 6-7 years to really tackle these challenges. And there's 3 prongs of this program. One is to develop models of rare cancers such as chordomas and maintain a living biobank where we not only house the samples, but we actually develop models that can be tested at our site, but then can also be shared around the world so any researcher can use them. We're then using these models to identify new therapeutic opportunities. And we're also, we've developed a data portal and the ability to essentially democratize the data so that anyone in the world can access it and identify potential information, both researchers as well as patients. So this is what we call our program, the Childhood and Rare Cancer Model Atlas Program, and you can see the three main names here. Question is, how can chordoma patients benefit from this? And the first one is the developing the new models, and locally we've done this through biobanks, integrating the biobanks from Monash Children and Royal Children's Hospital, starting from pediatric cancer. We've established dozens of new models for very rare pediatric cancer patients, including sarcoma patients, and you can see the process through which we do that here. But we realized that for rare cancers, really, we can generate one or two or three models, but in order to really identify therapies and then also identify which type of chordoma patient might benefit from the therapy really requires an international and global approach. So we partnered with dozens of different sites around the world. And the way our model works is that these sites send us tumor tissues or send us existing models, and we integrate that into a single site platform for analysis. So we're using these models, and we call them tumoroids. You can see here some of the sites that have contributed to this, including the Chordoma Foundation, which has sent us over a dozen different chordoma models, both cell lines as well as tumor tissues that can be xenografted into animals. And we've used these at different levels. One is in a more personalized approach. We can take a patient's existing tumor, grow it in the laboratory, and perform a screen in real time with their treatment to essentially identify therapies that can be more effective or combined with standard of care therapies. And we've done that in a number of cases. But most of our program really is designed to identify therapies that are really specific to the cancer, so we don't need to necessarily try to take a therapy that might work in leukemia and apply it to a chordoma. So using chordoma samples very directly and performing screens and molecular analyses to find what works best for chordomas. So for this next part of the talk, we will share with you some exciting data that's coming from the lab, and this is work that's really been enabled by the Chordoma Foundation 2-year grant that Josh Summers briefly spoke about. So it's really quite new. It's over the last 10 or 12 months that Jan and Eleanor here have been working on the chordoma models, and you'll hear about some of the ways that we're identifying new therapeutic targets, both drug as well as antibody drug conjugates that David briefly mentioned, and I will allow Jan to take over from here.
Afternoon everyone, I'm Yen and I'm a first year PhD student, so today I'll be presenting what I've done the past year as well as my research progress. So my research is to identify new treatments for adult and pediatric chordoma. My project is mainly concerned with the distinct biological differences between adult and pediatric tumors. So as we know that chordoma is a very rare tumor, majority of the cases are still adult cases and only about 5% are in pediatric cases. The general characteristics of chordoma is that it's a slower growing tumor compared to other cancer types, but in the pediatric subtype, it's said to be even more aggressive. There are few driver mutations that drive chordoma, and while there are very few, there are no available drug treatments, what my project hopes to do is to be able to identify more drug treatments to widen the treatment options available for chordoma patients, not just in adult patients, but also in pediatric patients. With increasing research in chordoma, we have found that there are some common mutations as well as emerging therapies for chordoma. This includes genes related to the gene packaging systems in chordoma, as well as important signaling pathways. These pathways are being targeted by current targeted inhibitors in clinical trials, as well as you all know, the Burkhardt TBXT overexpression that is very unique to chordoma is currently undergoing preclinical testing in terms of vaccines. But despite all of this, there are still mixed outcomes in these clinical trials as well as preclinical studies. That's why my project hopes to be able to identify more therapies so as to better result in better treatment options for chordoma patients. Currently, we have about 12 cell lines that are derived from patients that have been extremely useful in helping us better understand chordoma biology and also understand the differences between adult and pediatric chordoma. These 12 cell lines were in collaboration with the Chordoma Foundation as well as the CBTN, and it has been really helpful in allowing us to better understand chordoma biology between adult and pediatric patients. So out of the 12 cell lines, we have 8 that were taken from adult patients and 4 that were taken from pediatric patients. Over the course of the year, with the help of my other lab members, we've managed to get data in terms of better understanding the genes and proteins in chordoma tumors. And over the course of the year, we hope to be able to expand this to include more cell lines as well as more data so that we can better characterize the molecular landscape of chordoma. The main therapeutic challenges that my research hopes to address is that chordoma is known to have very different and few targetable mutations. What the diagram on the right essentially shows is the difference between the molecular profiles between adult and pediatric chordoma. What we did is we sent these samples for sequencing and tried to find out what genes were mutated in these tumors. By doing so, we can better understand the differences between adult and pediatric chordoma and therefore have a clearer idea as to which drug targets we could use to treat age-specific chordoma. So the different colors essentially represents different types of mutations, but what this diagram I hope shows is that there are very different tumor mutations per cell line, which also suggests that there are very different mutations in each patient. Therefore, there's an increasing need for us to find out what precise treatments we can do to treat each patient, and there is no one-size-fits-all treatment that we hope to address here. Also, aside from the limited treatment options, we know that chordoma patients are generally resistant to chemotherapy, which is why we hope to be able to broaden the wider range of drugs that we can use to better treat chordoma. What my project is doing is we're trying to use a gene editing tool called CRISPR. What CRISPR does is it helps to switch off the gene function in cells. And this includes being able to switch off more than 18,000 genes in the whole genome and find out exactly which genes we can use to be suitable drug targets. These genes usually may not be revealed just by whole genome sequencing. So by using these genomic screens, we hope to be able to find and reveal more genes that we can use to target with therapies. Therefore, if we turn off one gene and it causes cell death, it's likely that this gene could be a potential target for drug treatments that we hope to find out more about. So throughout my whole project, I'm trying to find out which genes can help chordoma cells survive and which treatments can help target these weaknesses. Over the course of 1 year, I conducted CRISPR screens across 4 adult cell lines and 3 pediatric cell lines, hoping to find out consistently what are the genes that may be important in chordoma. On the right, it shows the list of top genes that I found after conducting these screens, and it confirmed known important genes that have already been found in preclinical studies. But in addition to that, we have also managed to find some top gene targets that we are looking to further validate as we go along in my project. In addition, we also tested more than 700 drug compounds, and we tried to find out which are adult-specific drugs that are effective in adult cell lines and which drugs are effective in pediatric cell lines. So what this graph shows essentially is that we have found adult-specific drugs that were effective in the adult cell lines, as well as pediatric-specific drugs, which is represented by the orange. Between the two, there are also common shared drugs that could potentially be used as monotherapies or in combination, and we are hoping to further investigate that. Another concept that we hope to explore in chordoma especially is something called synthetic lethality. So oftentimes we have one gene, but turning off one gene may not necessarily lead to cell death, which is the reason why a lot of clinical trials may have mixed responses, and single drugs alone may not be effective in treating chordoma patients. Therefore, what my project hopes to add on to that is to see what drugs used in combination can target both genes simultaneously. And by doing so, we hope that by targeting both genes with different inhibitors together, this will lead to synergistic and potent cell death. And this will ideally be able to provide more durable responses for our treatments. So through conducting these screens, we hope to be able to find what drug gene pairs can be used to help chordoma cells survive, and therefore how can we target again these drug gene combinations to provide better combination treatments. In my drug CRISPR combination treatment, I have conducted it on one pediatric and one adult cell line, definitely hoping to expand this to more cell lines as we go along. I treated these cell lines with 5 different drugs, namely alpelisib, avapritinib, alotinib, paxilosib, and ribociclib. These are drugs and targeted inhibitors that are currently approved for other cancer types and are currently under clinical testing in pediatric tumors, which can better help us understand what are the side effects in pediatric patients, and also find out whether these drugs can potentially be used in drug combinations. Aside from that, with this, we can also test more than 90,000 drug gene pairs and therefore be able to expand our research to include more drug gene interactions that we can further explore. In my drug gene combinations screening, basically, the 2 heat maps that are shown here. This represents the adult cell line that we tested on, and the right side represents the pediatric cell line that we tested on. From these results, we did find that there's very different sensitizer profiles between the adult and pediatric cell line. Therefore, once again, highlighting how we need to find precise treatments to treat adult and pediatric chordoma separately. Also, this data that we have found so far help us inform possible drug combinations that we can test further as we move along in this project. And I hope to be able to get more data and results and be able to share that soon. So my project hopes to go from discovery to translation. We're currently at the discovery stage where we have shortlisted possible drug targets as well as gene pairs that we can test further. Working with the Chordoma Foundation, we hope to be able to test this in vivo in mice models so that it can better provide stronger scientific rationale to be translated further. We hope that this, through my project as well as in collaboration with the Chordoma Foundation, we could then provide strong clinical rationale to design either new drugs or repurpose existing drugs to be used and tested in clinical trials, and hopefully be able to expand the treatment options for chordoma patients. With that, thank you.
Hi everyone, I'm Eleanor. I've just started my PhD, but I'll be talking about some work that I did last year as part of my honours year, which is looking at antibody drug conjugates, which you've heard a little bit about today, but I'll explain them in a bit more detail for you. So an antibody drug conjugate is an antibody that is chemically linked to chemotherapy drugs. This enables it to be targeted to the cancer and deliver the drug directly inside the cancer cells and not to the rest of the body. This offers a benefit of fewer systemic side effects that you would normally see with traditional chemotherapies, and enables us to use drugs that are stronger than could normally be used in patients, which can help overcome resistance, which is really important in the context of chordoma, where traditional chemotherapies are ineffective. So I've shown here that the process of an antibody drug conjugate working. So the antibody has 2 binding regions that bind to a specific protein. So we find proteins that are expressed on cancer cells, but not on healthy cells, which enables them to sort of have that targeted biological missile action. Once it binds to the surface of the cell, to this protein, the cell takes the whole antibody drug conjugate inside through a process called internalization, and then it is broken down to release the drug inside the cell, causing cell death. This is a bit of an overview of ADCs that are currently used in clinical practice. There's a variety of targets shown here, and they use different drugs and from different types of drug classes. However, there's sort of one common theme, and that is, unfortunately, they're mostly used in breast and blood cancers. Few, if any, targets have been identified in rare cancers, and particularly has been identified for chordoma. So we aim to use the data that we've been generating, as Ron mentioned, to find targets in chordoma for an antibody drug conjugate. Overall, my project aimed to identify a target and then confirm that that target could be used for an antibody drug conjugate in our chordoma cell lines. So we looked at the mechanisms of action, like does the antibody drug conjugate go inside the cell, and does an antibody drug conjugate work? To firstly identify a target in a targetable protein for an antibody drug conjugate, we started with this proteomics data. So proteomics data is basically a list of all the proteins that we could find in a cell. We then split that into what we know is on the cell surface and what is inside the cell. Looking specifically at that cell surface, we then compared the proteins in chordoma to non-cancerous cells to identify proteins that were really highly expressed on the surface of the chordoma cell, but not in healthy tissues. We also used some other data sets to supplement our data, because as we all know, chordoma is rare and there's very few models, which helped us to sort of prove our hypothesis with a bit more certainty. What this came up with was quite a range of targets that could possibly be used for an antibody drug conjugate in chordoma, but the most interesting of these was CD70. It had the highest expression on the surface of the chordoma cells. There was lots of CD70 on chordomas and very little in healthy cells. In fact, it was found in no healthy cells, no categories of healthy tissue like skin, lungs, brain, at a higher rate than it was found in the chordoma, which makes it a really promising target for an APC. So to look into whether this, to confirm that the CD70 was expressed on the surface of the chordoma cells, I used a technique called flow cytometry, which is very complicated, but I have got a diagram here to explain what I did. So in flow cytometry, single cells pass through a laser and you measure the scattered light and the fluorescence of the cell. If we use antibodies like a CD70 antibody that would bind to the surface of the cell, and we add a fluorescent label to that, we can measure the increased fluorescence. So that gives us a graph like you see here on the right, with the blue showing our control group, which is just the baseline level of fluorescence seen in the cells, and the red showing where we have added CD70 with this fluorescent label, so there's an increased level of fluorescence where CD70 has bound. What we found is that CD70 was expressed across all of our chordoma cell lines. I've shown just 3 here across a variety of different expression levels. We have high, medium, and low. In our highly expressing groups, almost 100% of the cells were CD70 positive. In the medium group, it was about 66%, and in our low expressing group, it was 20%. But overall, CD70 was expressed in the chordoma cell line models, which was a really promising first step. So we went on to further investigate whether we could see if CD70 went inside the cell through that internalization process. To do this, we used something called a nanobody, which is derived from an alpaca antibody, which is just a little bit different to a mouse or human antibody. But what it gives us is this really small tool that we can attach to an antibody, and then we can do lots of cool things with it. Like this one we had, we used a specific dye, which outside the cell has no color, but once it's taken inside the cell, it starts to fluoresce red. So we were able to visualize with the CD70 antibody when this was taken inside the cell. So up on, sorry, that's probably off this side. Can you see? Yes.
Yep.
Here we have our control group, so there's no internalization of an antibody occurring in this group. But underneath you have the group with CD70. So in these cells you can see where CD70 has been internalized, the cells glow red. So we can see there's good internalization in our high and medium CD70 expressing groups. Not so much in the low expressing groups, but that's okay. And graphically, we measured this as well, so we can see almost 100% of cells in a highly expressing cell line take inside the CD70 antibody. knowing that, we really wanted to test if a CD70 antibody drug conjugate would work. So we had this CD70 antibody drug conjugate, and we wanted to test it in a cell line that had CD70 and a cell line that didn't have CD70 that we could directly compare. So ideally they'd be identical in every aspect except for their CD70 expression. So to do this, we used the gene editing tool that Jan talked about in her project called CRISPR to knock out the gene for CD70 to create this identical cell line that just didn't have any CD70 on the surface. Those cells without CD70 are shown in the blue, and you can see as it goes to the right, there's an increase in concentration of antibody drug conjugate, that with increasing concentrations of the drug, there is not a decrease in the viability of the cells, so they're not dying off. However, the cells that were unmodified, that still had CD70 on their surface, almost all of them died in the presence of this antibody drug conjugate, showing that really targeted mechanism of action. So the CD70 ADC is killing only cells with CD70 on their surface. Finally, we also wanted to look at things other than our cell line models. So these are some tumour samples that have been stained for CD70. CD70 shows in brown, and the blue dots are the nucleus at the centre of the cell. We found that 80% of these models were positive for CD70, which is really promising. So potentially 80% of these chordomas could benefit from something like a CD70 ADC. But there's still a lot of work to be done. It's exciting, but we are still in sort of this target identification stage. There's a bit of optimization. We have to find the right drug to attach to the antibody, and then before it could continue to further preclinical testing and maybe a clinical trial. But I wanted just to highlight that there are some CD70 ADCs that have been developed for other cancer types that are currently in early clinical trials looking at their safety profiles. And there's maybe an opportunity there for repurposing into chordoma. Thank you.
Focus the discussion on how can we take these new therapies that you heard about from Jan and Eleanor, exciting therapies in the lab that are working well, but the stark reality is that we have more targets and more therapeutic opportunities that are working, at least in the preclinical laboratory space, than we can actually work on ourselves. And this gets into the area of breaking down data silos, making sure that researchers and clinicians really work together, because it takes a laboratory finding and put it into the clinic. It takes a very large effort, engaging clinicians, researchers, industry, and the only real way to do that is to work together and democratize the data so that we can all use it. So we've, over the last few years, built a bioinformatics team, and the team members are shown here. And really the mandate of the team is to build data resources that will enable this democratization process. In addition to that, the team also uses more sophisticated computational approaches, what we in the research community call AI. It's not large language models, but it's what we call machine learning. So these are computational tools that allow us to sift through hundreds, if not thousands, of patient samples and models and really start to link therapeutic responses that we see together with biomarkers, mutations, or other alterations so that we can identify therapies that work best for each individual patient, so that when the patient comes in, they can be matched into a clinical trial that has the best chance of working for their specific tumor. So with that, we built this portal. You can see the URL down below, and this is just a screenshot of the portal. We have not just chordomas that have been analyzed, we have many hundreds of different rare cancers, particularly pediatric cancers, different forms of pediatric brain cancers, but also different types of rare sarcomas. So you can see here over 60 bone and soft tissue sarcomas, neuroendocrine tumors, and others. And having this large data set really enables us to then find specific correlations and specific therapies. So we can ask what works in chordomas, but we can using this data show that the drug that we find or the ADC that we find is specific to chordoma, so it will only work, let's say, on chordomas compared to other cancers. And that gives us an indication that this is really likely to be a precision therapy, and not necessarily something that is generally toxic to all cancers or to normal tissues as well. So I'm not sure I'm going to be able to share the video part of the presentation, but I did have a bit of a video to show you how we're sharing the this kind of data. The idea is that we built an interactive module that it essentially allows you to type in the name of a drug, type in the name of a tumor type, and very quickly be able to see what is effective in that tumor type or which kind of mutation predicts a response to a particular therapy. So that is a tool that we're building and is an add-on essentially to our portal. You can find it in this analytical portal box here. So this is up and coming, and stay tuned for that. So, looks like it's working now. So essentially what you're seeing here is just a part of our data portal. So here I put in the name of the cancer type, so searching for chordomas. Searching for EGFR, which is a known target in chordomas. You can see here the different features, looking at the mutations, the expression of EGFR. You can see that this shows us essentially that EGFR is highly expressed in chordoma models that we have compared to some of the other cancer types. You can see that a little bit closer here. We can also see the specific cell lines and the specific models that we have that express the target of interest. As part of this, we've also built a drug module called Related Drugs, so you can look up the EGFR inhibitors, and they're shown here. And you can see one particular inhibitor, AZD3759, and this inhibitor, our finding is that it works very well specifically in adult chordomas. And then, as I mentioned, we can also look generally at the adult and pediatric chordoma subsets. And this shows us, you can find here the models that we have and what's been performed on them in terms of molecular analyses. You can also look at the CRISPR genetic target screens that have been performed on these models. And this will immediately compute the most specific genetic targets in the cohort that we've identified, so you can see specific targets that are particularly essential in chordomas. You can see here, if we look up one of the targets, KLF6, there's currently no drugs available, so this is a target that would need to be further investigated in terms of developing a new therapy unlike EGFR. So hopefully this gives you a flavor of both the therapies that we're finding in the lab, but also the ways that we are building resources and tools to be able to share the data with the community. So I'd like to obviously acknowledge the research team, Jan and Eleanor, who've done really a fantastic job in only 9 months in performing these very promising analyses and targets that they've identified. Obviously, I want to thank the Chordoma Foundation for providing us with the support to be able to do the research, and opening the first Chordoma research lab group in Australia, so that's very exciting for us. And obviously thank as well the patients and families. So all of the Chordoma models that we are testing are derived from Chordoma patients. And we wouldn't have been able to do this without the generosity of the patients and the communities in consenting and providing tissues to enable this type of research to occur. And thanks as well to Chordoma Foundation, Dan Freed, who has been not just a funding opportunity for us, but also interacting with them directly in terms of the research and being able to work closely and collaboratively to move these targets forward. So thank you again, and we're happy to take any questions.